Thank you so much for having me. So in health, the thing that drives our agenda is one question when we do research, and that's how many lives is our research saving? And when you talk to people in public health, it turns out, as a little bit of background for you all who aren't familiar, we've kind of lost sight of that first love about why do we do what we do and why do we do it for an impact. And we just do it because we like research, we like interesting questions, and we forget that we're actually interested in saving people. And part of that problem is because in public health, and this isn't true of most of academia, it's a top-down enterprise where the assumption is we're data-starved and we're resource-starved. Collecting data requires primary collection, millions of dollars, planning on deciding what to include and what not to include, and then analysis takes lots of time and a large team of investigators and a great deal of expense. And that means in public health, the questions we're investigating today are questions that we picked 4, 5, 6, 7 years ago. And they may no longer be relevant. So we may be asking the wrong question, and that's because of this top-down, elite-driven enterprise where a few people who happen to own philanthropies or work in the government decide what questions we can and shouldn't be asking. But I believe, and I know you all will be receptive to this message, that there's a bottom-up framework. And that is knowledge resources are abundant. You don't need to be a psychiatrist to make a meaningful contribution to the mental health field. Google Scholar is going to make you an expert rather quickly. Data is right there at your hands. We also have, data on demand, news, social media, internet searches where we can get data for free. It's readily available, easy to analyze. And we have, at the same time, infinite pathways to distill our knowledge, right? We can have this organic advocacy where we're actually doing research not to reach the people who happen to read JAMA or the American Journal of Public Health, but to reach the public themselves. And so this results in a more agile science where we're more aware of the needs of the public and we can respond to those needs. And so what I'm going to talk to you about is a little bit about our framework of how we do need-driven public health using data science. And we'll talk through 4 different stages. Part 1 is enhancing what we think we already know. So whenever you all talk to someone who's a health expert, they'll tell you, well, we know this, that, and the other. But they never tell you what the evidence is for that inference, right? They're always confident in the knowledge, but they never tell you what that's based on. Well, it turns out if you start looking, what they think they know is based on really poor evidence. Take, for example, the idea that people quit smoking when we raise cigarette excise taxes. How do we know that? It turns out the evidence is based on things like counting cigarette butts in the parking lot. Right? Or looking at people getting prescriptions for Chantix at the pharmacy. Or people calling a quit line where most people don't even realize there's a free 1-800 number to quit smoking. So we're using measures based on a small subsection of the population instead of measuring large swaths of the population. And so things we think we know very well, we may not know. So we present an alternative to that method. And we say, we can learn the same kind of thing. Here's an example of a time trend of internet searches for smoking cessation in the United States. There in the middle, that spike is the children's excise tax increase, where they increased the tax by about $1 nationally. And we can see that effect that people expected, but now we can see it with much more granularity, much more objectivity in terms of face validity, where we're seeing literally millions of people searching for how to quit smoking. Instead of studying a single event, though, we can also study multiple events, right? So we could look at like an excise tax increase on tobacco products in Florida or in New York in the bottom panel. And we can estimate what the impact of those changes and taxes were on people's intent to quit smoking by searching for methods about smoking cessation. But we're not limited to just one outcome now, right? So we can see many, many outcomes. And that means we can see things that before we never would consider. Like people trying to figure out how to avoid the tax by buying tax-free or tax-reduced tobacco products from Russia or Indian tribe reservations. And here we can see that actually the public responds much more readily to that, trying to avoid the tax, than they do actually trying to quit smoking. Take another example of something we know. Everybody in the room has probably heard of seasonal affective disorder, right? You feel blue in the winter because less sunlight. We don't exactly know the mechanism, but you don't know other times of the year. Well, where does that really come from? It comes from the fact that most outcomes are really rare. So we can't study time periodicity in them, right? Schizophrenia cases are rare, or new presentation of cases or increased severity cases, so we don't have a time trend for that data, right? We have our once a year annual survey snapshot. So if you look at studies like this that try to go beyond seasonal affective disorder, they really can't tell you anything. So instead, we looked at people's searches again. Here in the United States is in blue, and Australia in red over several years in that wavelet transform. And you can see that there's more searches in the winter than in the summer for people suggesting they might have depression. But now we can also see that across various mental illnesses, ones that we never considered, right? We never thought about seasonal affective disorder when it came to anxiety, bipolar, eating disorder, schizophrenia, suicide, etc. And so here's a new finding that we didn't know exists, where we're unifying mental health, where it's no longer Axis 1, Axis 2, Axis 3, Axis 4 disorder. It's now there's this uniform periodicity across all mental illnesses, right? What's potentially driving that? Well, some skeptics looked at it and said, well, duh, John, you're seeing smart kids over at UCSD Medicine search for these disorders when they're learning about it. So clearly that's the effect. No. Here's examples of searches, the difference in the peak and the nadir during winter and summer. And for each city, we can actually see the further you get from the equator, the larger that difference becomes. So it's actually daylight, right? If you live in Boston, the difference in searches for schizophrenia symptoms is a lot more pronounced in the winter versus the summer than in Florida. And this is true across many, many cities. One thing we can do is also learn about new discoveries, asking questions we would never know what to ask about. We've done this several times before. One of our claims to fame is back in 2010, we were talking about electronic cigarettes when people really didn't know what it was. And I remember we sent a paper to JAMA and we said electronic cigarettes are hugely popular on online forums and in internet searches. And editors like, I've never heard of it, it doesn't matter. Right? The opinion becomes the basis of discovery. So here I'll show you some examples of some things we did with that, based on periodicity. When do smokers want to quit smoking? Right, so here we see time trends for internet searches again, by day of the week. And we can see that there's increased interest early in the week, Monday and Tuesday, compared to later in the week. When do federal agencies and allied health groups buy advertising for people to quit smoking? Saturday, the worst day, because the assumption is people have the free time to engage in a new lifestyle choice. Let's do it when it's readily available to them. And it turns out this is true everywhere, right? So here I'm showing you examples of 6 languages, and we see this same periodicity replicated in all these languages. In addition to understanding when and where people are potentially interested, we can also answer why with these types of data. So for example, going to another product, like why do people use Juul? Why do people use e-cigarettes? We can answer that, right, by mining social media data. So here we can actually see the reasons why people engage in using a product like e-cigarettes and how that changes over time from 2012 to 2015 by mining their Twitter posts, where they're explicitly saying in the profile, I have used e-cigarettes or currently use e-cigarettes, and they're expressing a reason why they've used e-cigarettes somewhere else in their profile. And so we can see in 2012, people were really interested in quitting, but later on, it was more social image, right? It became a smoking alternative instead of a cessation device. A huge missed opportunity. The public saw something as a way to improve their health, and now they see it as that cool thing you want to habitually do all the time. We can also contextualize this data, right, with demographics. So not only can we replicate what a survey can by theoretically asking someone what their intention is, we can observe that on social media, but we can also observe among whom. The basis of validity for all the work that we do in primary data collection is we talk to the right people and we ask the right questions. Well, now we can know if we talk to the right people. So for example, looking at that same outcome, why do people use e-cigarettes? It turns out it differs by the gender of the poster, right? Women much more likely to be interested in using for social image compared to men. We can also make new discoveries around things we might not otherwise expect, right? For example, where do people get clinical care, right? We know that it's difficult to get to the clinic. Even after the Affordable Care Act, there's still barriers to entry just getting there, even if you have free or subsidized insurance. So where do you turn to help? It turns out they're turning to social media, right, to get crowd diagnoses. Before we thought about self-diagnoses, physician diagnoses, well, now there's crowd diagnoses where you can go to your peers and ask. So what's a way we can test this new phenomena and see how it exists using an outlandish case study of people taking pictures of their junk and posting it to Reddit and asking what that dot is. And here we see that. These are posts to Reddit on RSTD. And we can see the trend going up over time. And here we can see examples of those posts where people are explicitly getting a crowd diagnosis, where they're asking, help, what is this? I see this dot here. I want a diagnosis for my peers. So we saw that and we were surprised, but we were even more surprised by what else we saw. By the way, 53% of posts were people seeking a diagnosis, the majority of all posts. But among those, a large plurality of those people, about 1 in 3, had actually already seen a doctor, and they wanted the crowd to tell them how their doctor was wrong. Here in the bottom, this is a summarization. This is exact quotes, because I don't want to protect the identity of some of these public posts. But this is a true incident where someone got an HIV positive test result and then went to the crowd to ask, this must be wrong. And guess what they were told? Yeah, it's wrong. Here's some metrics from that we talked about before, but I want to ask something a little bit about this. So knowing crowd diagnosis exists, right? We say this is a new phenomenon, it should be studied, this is what people are doing in this outlandish case. What do you think the reaction to that was? Shut it down, right? They're putting us out of business. We need more patients, right? This is bad. But the reality is this new discovery could be something that's good, right? It could be good to have a place where people can share information if we can curate the type of feedback they get and curate the situation in which they solicit feedback. So surprisingly, rather than saying shut it down, we had a very different narrative in the media. So I've told you how we can learn things we already know. I've told you how we can learn things we never would expect it. And I had to look at a lot of those pictures, unfortunately. I can now tell you about how we're missing opportunities to have an impact when it comes to data science and health. What's the biggest health impact probably in our lifetime? I'll give you a hint. It's the recession, the Great Recession of 2008. Right? We know that when there's economic collapse, that it results in poor health, because guess what? You lose your health insurance, right? You no longer have access to care when you lose your primary form of employment. Health is a collateral. Well, it's a commodity that's a luxury good to many people when they can't afford it. So they have to cut back. So during the Great Recession, when we had trillions of dollars on the line to address the potential health cost offsets related to the economic collapse and how to address it, what did public health leaders have to say about it? Opinions, because there's no data, right? The traditional data they have is, well, way back in Korea, when after the Korean War, we saw increases in all-cause mortality, so we should be concerned about it. Instead of turning to actual data. So what we did in that case at the time was say, well, what's the cost offset for health? And here's people searching for psychological distress, like, I'm depressed or anxious or suicidal, etc. And we can see it increases along major events of the Great Recession. And we can also associate it to time trends in unemployment, underemployment, and homes in delinquency or foreclosure. And that is, when homes in delinquency and foreclosure went up 1%, we expected psychological distress to go up 18% 1 month later. And then, or 16% 1 month later and 16.5% 2 months later, et cetera. And we can see this durable effect, right? That as the economy changed, there was unique health consequences that we could directly observe. And it was lasting months. But the things we spent trillions of dollars trying to prop up, do they affect health? No. Right? So what if in Congress we were thinking about the health consequences of the recession when we decide how to implement our monetary policy? Would that change how we address the Great Recession? Maybe. One way it could help change it is by looking at specifically what the outcomes were. So here in the top is an example of thousands of unique search queries related to health pre and post recession and a mean trend over that spaghetti plot. Here's an example of 2 of those queries. People searching stomach ulcer symptoms or headache symptoms and how they increased over expected levels as the recession happened, right? Increasing in that case more than twofold for each of those. And we can see specifically how queries increased, right? So stomach ulcer symptoms increased at 250% relatively, and that represented about 3 million excess unique searches during the Great Recession for that one specific outcome. And here we show several hundred. Now, you probably can't read all those names here, so I'll talk you through it with some categorizations. When you look at the categories of what people were searching for, we found some surprising things that make sense in retrospect but weren't in our literature, right? A lot of interest in toothache, a lot of interest in pregnancy. But we didn't think about that before, but when you see the data, it kind of makes sense. Well, what do you lose when you also lose your insurance? You lose access to birth control, right? When you have to spend out-of-pocket expenses, what do you take out first? Your teeth. Less important than your heart. So I'll give you another example of something new. What's the biggest thing happening today in health? CBD. Right, CBD is insanely popular. And in April and August of last year, there was 16.9 million Google searches for CBD in the United States. And there's an increase in the trend. Each state, you can see this is happening nationally. All states are going up, projected to continue to increase. But to give you an idea of how popular it is, CBD is more popular than people searching for exercise methods or advice, vaccination, meditation. More popular than marijuana, almost as popular as yoga and e-cigarettes, which is really interesting. It's a derivative of the marijuana plant that doesn't contain THC. Well, it does contain THC, but that's another thing. So it's a snake oil for this generation. So you can buy it at Whole Foods and Rite Aid, online, MedMen, and you take it and it has no benefit, but it's insanely popular. Which I ask, why doesn't the FDA do something, right? It's because we didn't know CBD was coming, so we don't have the money and the resources to have data. So the FDA commissioner, when he goes to Congress to explain what are we doing about this, he goes, well, we would do something if we had data on this specific outcome. If only we knew that people were using CBD as a true therapeutic, would we do something? And that's going to take a lot of time, and we may know in 2022, and then we'll do something. Well, we answered that question for them in a couple of days. So here's an example of people going on Reddit and giving testimonies about why they use CBD. And you would think wellness would be very popular. I want more energy. I want to feel better, my mood better. I just feel stressed, or, some idiopathic reasons for what their health is. And we do see that. We see about 30% of posts, mention wellness as a reason they use it. But the vast, vast majority of people are using CBD to replace effective treatments for diagnosable conditions, like heart arrhythmias. People having AFib, searching for, not searching for, but going on Reddit saying they switched to CBD because it feels safer than the medication their cardiologist gave them. Or people taking it for erectile dysfunction, etc. So now we see people using CBD to move away from approved therapies for outcomes that are easily diagnosable and easily treatable. So now they're going to suffer, and suffer longer, unnecessarily, because we don't crack down on the CBD marketplace. So I want to talk now about examples of making a difference, which is why I want all of you to get interested in health, right? Because you can make a big difference. And I want to tell you a few stories about how our work's made a difference. And in these stories, I want the narrative to be, it's easy, right? You could do this. Everybody can do this. You could do it better than me. Charlie Sheen said he had HIV, right? He went on Today's Show. He said he had HIV. And it was huge. I remember, like everybody, I saw it in the news that morning. I looked, I'm like, well, what's going on? And everybody's talking about him there. But Matt Lauer didn't ask, well, what's the impact on public health of this disclosure, right? Federal agencies didn't go, well, what's the impact of Charlie Sheen saying this? What can we do to impact public health outcomes? There wasn't that discussion. It was missing. But it turned out the public, thanks to 20 years of consistent messaging on get tested, always use condoms, they knew how to respond. Here in the far left side is news stories about mentioning HIV. We can see that trend. We can see that huge spike there around 2016 going off the chart. And here we can see people searching about HIV, right, where people are interested in HIV. Of course, it goes up. News went up 400%. Searches go up. Searches go up 400%. News goes up 265%. My apology. And so we can see that increase. But because they had that narrative, they knew how to respond. So here we see people searching for condoms, HIV symptoms, HIV testing, and we can see how, for example, testing and symptoms went up immediately that morning, the hour of the interview, and how they stayed higher for 2 or 3 days. We can also see that night, when they're like, maybe I need some condoms, they thought about it then, right? They didn't think about it at the time of the interview, but later on that night, you can see the periodicity in it and how they had that increase, and it lasted about a day. So without spending any money, without anybody asking the right questions to Charlie Sheen, without anybody trying to elevate this effect, there was this organic effect by simply awareness about HIV coupled with an understanding of what to do that the public responded. Now, when we talked about our study a few weeks later, it was insanely popular, right? And one of the benefits of that was we got to work with OraQuick. They make HIV testing kits. And they said, we'll have barcode data in about 60 days. We'll give you the barcode data, and we want, maybe you could look at that. And sure enough, what we saw for people searching for testing mirrored with testing results, right? Testing pulled by week, we saw that increase, similar to the increase we saw over those 3 days for searches. But we also saw the effect of the Charlie Sheen effect. And that is by simply talking about Charlie Sheen and publishing a study and talking about that study in the media, we created an echo effect where testing sales significantly went up. And if you look at the time trend data for HIV testing, the all-time high is Charlie Sheen. Us simply talking about Charlie Sheen a couple weeks later in the news was about the 11th biggest effect ever. It was 7 times bigger than World AIDS Day. It was, I think, 6 times bigger than National HIV Testing Day. Just talking about it, right, while the public's engaged. Doing science, you can have a direct impact on the outcomes. I want to talk a little bit about another example of Pokemon. May I have another water, please? Whoever's in charge of water. They're not listening, it's okay. Can I have a water, please? Pokemon, right? So Pokemon Go comes out. It's hugely popular, and guess what everybody says? This is great. Pokemon's great. Fat people walking. It didn't work on me. I still stayed behind the desk and didn't walk. And I also realized at the same time that I'm fat. I don't like to exercise. But if I like Pokemon Go, what would I do? I'd cheat. I'd drive around in the car and play the game. So the week after Pokemon Go comes out, we do a little study, publish it in JAMA Internal Medicine, and we show that, guess what? If you go on Twitter, people love to tattle, and they're like, my mama is cheating playing Pokemon Go. She swerved and stopped the car. I just saw this kid get clipped by a car trying to catch a Pokemon. So we can see people, drivers, we can see passengers reporting on it, we can see pedestrians talking about it, and we can see people talking about how there's a substantial increase where of these posts, 33% of posts mentioned in Pokemon Go actually mentioned a driver, passenger, pedestrian being distracted by playing the game. You're not talking about losing weight. Now, we didn't need $1 billion. We needed to convene a tribunal in Washington, D.C. to decide we're going to study this phenomenon. All we needed was to publicize that outcome. And fortunately, the CEO of Niantic saw, and they made the game safer by reducing gameplay at driving speeds. You know, they set the precedent, right? We didn't need this top-down intervention. We just have this organic bottom-up. Now, Niantic doesn't want to kill people, right? So, of course, they can make the game safer. And they did. I'll give you one last example. How many of you have heard of 13 Reasons Why or watched? Everybody's heard of it, Lord. Not even you have, don't pretend. So, 13 Reasons Why is a popular Netflix drama that broke all the rules. And that is, in health, we know that we don't want to encourage copycat suicides, so we never talk about the modality of suicide, right? We never discuss the suicide. We always frame the suicide in important ways to show that suicide's not an answer, right? That kids don't go and kill themselves in a copycat way because they see that as a solution. And 13 Reasons Why broke all those rules, right? For example, the very first scene in the series, the primary character's already committed suicide, yet she's alive. She goes to the prom. Her boyfriend likes her now, right? She's popular now. It solved all her problems. And that's exactly the type of thinking we don't want to promote. And we know that type of thinking causes negative outcomes. Well, when 13 Reasons Why broke all the rules, people said, you're breaking the rules, and they're like, show us the data. Well, we care about data now, so we won't do anything. So we showed them data now. So here's people searching for suicide, where they're including searches that we believe to be about suicide. We can see what the expectation was. There's the line showing the release of the program, and their search is increasing, right? We can see this huge increase in interest in suicide, and you might be like, well, that's a search. What's a search mean? Well, we'll let you decide what the search means. So, for example, people searching for how to suicide increased 20%. People searching for how to commit suicide increased 30%. So you can see people actually engaging and thinking about killing themselves. Unbelievable. While they're putting this program out there to air. And when we confronted them with it, here's what they had to say. Right? This doesn't mean anything. We're the experts. We know how to do it right. And I remember talking to a dad, and he found his girl. And the program was on the screen, and she'd hung herself in the closet. Unbelievable. Unbelievable. And while this is happening, and Netflix is saying this, public health is saying, well, we're going to wait for better science. So it took literally 2 years to get Netflix to do something about it, before they added a warning, and before they took down parts of the series that glamorized suicide. 646 days passed when they waited for confirmatory evidence when they saw these studies, which were based on survey data or electronic medical record data. And it's not right. Right? Ignoring data is costing us lives. One suicide is too many. One person getting killed by a car in Pokemon Go. Right? One person not getting tested for HIV when they could get tested and reduce the chance of transmission is one too many. So we need to not ignore that data. So how can people like you help? Well, one way people who have the skills that you have can help is by facilitating research, right? And helping to build tools that can make non-experts like myself, who come from a health background, have access to data that can inform our day-to-day decision making. I'll give you an example of one of the first efforts at this was Google Flu Trends. How many people remember Google Flu Trends? Okay, Google Flu Trends 2009. So Google's like, there's a 17-day delay between influenza illness reporting by the CDC and when it's available, right? So if you ask me how many people have influenza-like illness today, I will tell you the number from 17 days ago, right? But with searches, we could get real-time data, and that's great. But it turns out the system failed. And so the reason it failed was not because the limitations of the approach, which everyone said, well, this approach is bad. Of course you can't learn anything from these types of data. It's not the type of data we traditionally work with. It was just a method. So we fixed Google Flu Trends. We built a simple lasso model, just basic machine learning. And here you see our predictions in blue that are made 17 days in advance of the black line. And we see our predictions. And we can see Google Flu Trends. And we can see that our average estimate and what that effect was, I think we were off by, our REMA model was, we were off by 0.3% on average. And here we can actually see the specific queries that go into our model. Like indoor driving range, our model throws that out rather quickly. And our model will adjust and take in things like symptoms of flu or how long is flu, we'll throw it out. So we can have this dynamic modeling. And we can actually see how it changes around different outbreaks. Like here in black is the H1N1 outbreak. And we can see our model adapts and how it takes in data to make a more accurate forecast instantaneously. But what about other things like flu, where we don't have data, right? I told you how many people have depression. I'll have to tell you about 2018, a mean estimate for the year. Well, there might be a way around that. And that is, in public health, we rely primarily on one survey called the Burroughs. We interview about 400,000 people every year. And it turns out we interview all year long to save money. And when we interview, we ask them all sorts of health questions. And if we think of the survey not as an annual estimate, but as a monthly estimate or a weekly estimate, maybe something different. So here's interviews happening per day. And we see there's lots of interviews at the beginning of the month because they're trying to meet the quota. It falls off at the end of the month because they met the quota. But look, here we're showing that on any given month, we're getting in between 30 and 40,000 interviews done. That's enough to make a pretty confident mean estimate for that month. And now take that data and turn it into a time trend. Here's people with, this is a clinical outcome. A Kessler serious psychological distress is in black. And here in red is our model based on searches. You can see our predicted outcome versus observed outcomes. And you can see we do a pretty good job of predicting that. And so what do we do with that? We make mentalhealthtrends.org, where people can access that type of data. And we've done that for a few different things. We've done that for smoking trends, et cetera. But now I want to show you an example of something that we've been doing on tool building that may excite you some. So this is TobaccoWotcher. So we've talked a lot about search data, social data. This is based on news data. So what this is basically the Bloomberg terminal for health. This is the free section of it on tobacco. We have free sections on tobacco and guns. Soon marijuana will be public. So we have 350,000 different news sources we monitor every day. Think of all the various APIs, RSS feeds, and then we scrape data from about 50,000. We operate in 23 languages. That's every language spoken by 1% of the population, all relying on automated NLP. Here's an example of the most popular article of the month because we see the how many times it's shared on Facebook and Twitter. Article, Aussie smokers will be paying $48.50 a pack this year. That's in the Daily Mail. It was published, I don't have a date on this, a day ago, I think. And here's the article. I could read the article here. And here's our automated NLP working, where we think this article is about prices. It's authored in English. It's about cigarettes. We found one exact duplicate of this article. And we got this one wrong. We thought this was global non-specific, even though it's about Australia. Where our machine learning, depending on the outcome, has an accuracy of about 0.85. So you'll see errors about 3 every 20. So we could dive into that database, right? So we could use any number of the filters. So here they are sorted by most recent. This platform has about 5,000 active monthly users where they can use this. So you could filter by any of these categories based on what the primary subject is. So I could be like, well, what's the one on prices? And I could see those articles. I could see articles primarily talking about minimum age laws, bans, flavor, industry. Let's pick flavor. So here's an article, for example, New Jersey bans menthol in e-cigarettes. It's published 5 hours ago, primarily about flavors, United States, English. It's about e-cigarettes. Now, I've just heard about this. This happened 5 hours ago. I'm not cherry picking an example. This happened then. And let's say we don't know anything about it, right? The model before we had access to data I need to track down the expert on flavors, state legislation, send them an email, talk to them, pay them to consult. Not anymore. You can click one click, and we'll collate through our database and try to provide you with a timeline of what happened there. Well, here's the article 5 hours ago talking about the ban. Here's an article from a day ago where they talked about where the governor signed the bill a day ago. Here's talking about the bill was going to ban. Here they're talking about they're going to vote on it. So now I'm an expert on this event instantaneously. And you can do this for any number of phenomena on the site. I'll show you one other cool example of smart history. I put it up here so we can see it. Here's an example of an article. FedEx had to pay a $35 million fine for cigarette smuggling. It was the state of New York because they were distributing tax-free or tax-reduced cigarettes from foreign nations or independent tribes, Indian reservations. So I can see that. And I can see the history on that. I can see FedEx plans to settle. $35 million fine coming. I can see when they were accused a year before. I can see the initial lawsuit was for $235 million. I can see UPS is facing similar problems. Right, so I can become this expert. The other thing is it changes our perspective some. Do you notice anything about this focal article I picked? It's written for an investment blog in Russia, and it's written in Russian. So what collateral information can I learn about what's happening in Russia, maybe with similar actions, from reading this article, right? Or what could I learn by reading articles that were written in Chinese, for example, about what's happening in China? So I have this now a global perspective on what I thought was a New York issue becomes a global story with global implications, which is an interesting thing to consider. I'll go back to that flavor example because I just want to use that again. Smart history. We can also see we're now sharing tweets about that. So this article is 5 hours ago. There's been one tweet, and here's the tweet. So we're now in the process of sharing social media content and also automating some of that social media analysis so you can know like not only what events are happening, but what the reaction to the event is. You can create alerts. You can do analyses. We'll do an analysis. Something interesting that happened recently with e-cigarettes was the vaping illness outbreak. Everybody heard of that, of course, right? Let's do an analysis and see when and where it happened. So I'm going to call this vaping illness outbreak. Well, I need to learn to spell first. We'll use abbreviations. So I want articles primarily warning about the dangers of the product. I'm interested in articles primarily about e-cigarettes, right? All fully automated. Let's look at that time trend. So here we can see the trend for the past 12 months, and we can see this rise that happens here around the time of the vaping illness outbreak. And it turns out with TobaccoWotcher, we can also not only see the time trend, but we can interact with the data. So here we see this first blip, this major blip here, or we see an early blip here. We can actually click on that and look at the data that's happening there and get the story behind the story, like what was going on. So that was the day the first victim died from the vaping illness outbreak, was when that spike happened. Right? And I can see those articles and learn from those articles. It's a very neat feature. In addition, we had products and subjects picked, but we can see geographic variation or subject variation. Let's plot another plot on there. Let's pick anything with Joule in it. So we're making no restriction based on automation, just all articles that happen to mention Joule. I can see a time trend. I can see during this 12-month period, of course, I can pick different dates. And of course, you can download the raw data. I can see most of those articles about e-cigarettes, which you'd expect, but they're talking about banning the product, warning about the dangers of the product, industry, how many people use the product, where they're talking about, like in North America, et cetera. And so you can actually use a platform like this to learn actionable information that people from the health community don't have the skills or resources to do themselves, right? And so That's the final step here, is we transform what we do to have an impact to save lives by building tools that make data available for real-time decision making. Because we have an audience of millions of healthcare advocates out there who want to do the right thing, who want to help people, and we can simply give them data to make and facilitate that change. And when we do, we can have this huge difference making impact. And so I want to talk to you a little bit real briefly about some examples of ways that you all could work with us to make a difference on some tools we're building. So we talked about Watcher. Cohort we're doing is, just like the Burfus is a survey of people. It's a passive where we demographically, just like let me step back a second. The basis of validity of surveys is demographic representation, right? The sample looks like America, looks like California. That too can be the basis of validity for social media. I realize we can go beyond that when we group and cluster people. So we're building we already have a nationally representative demographically notated cohort. I think it's 200,000 people from Twitter. And we monitor them, and it's like having a real-time survey. We can know the prevalence of outcomes. Crowd, we're doing some open-ended, the same NLP that we use on TobaccoWotcher or Cohort, we can do by giving open-ended questions to people and asking them to respond, and then analyzing those open-ended questions instantaneously. Ask About is really cool. Something we may be doing at a healthcare center near you in the short term. And that is, you will voluntarily give us access to your private Facebook data. You yourselves can participate in this by going to ourdatahelps.org and give us your private Facebook data. We will take that data and then create prompts about what doctors should be asking about. Because when you go to the doctor, what do they do? Do you smoke? Do you use drugs? Questions that are pointless to the vast majority of people. When they could be asking targeted questions based on who you are and not what you wrote on some survey while you were sitting in the lobby bored half to death. TeacherDoc is really cool, crowd learning. Imagine like a Reddit platform for doctors. It's HIPAA compliant where doctors can share case studies. If you work at all in healthcare, a big problem we have is surgeons love posting videos to YouTube and Facebook and Twitter, and that's not what we want in healthcare. That needs to be private. Public health trends and regulations now. If you're interested in regulatory science, that's a really cool product we're building thanks to the Burroughs Wellcome Fund. So thank you very much. You can contact me here. If you Google me, I'm pretty Googleable, and we'll work together.